Welcome to Nursing 203, Week 1, Chapter 82, Blood and Lymphatic Disorders. The homework for this had already been opened up on my IoT. We're going to be experimenting throughout the duration of this pandemic response with different formats. This is the first one we're going to try here. So without further ado, Chapter 82, Blood and Lymphatic Disorders. First off, hematopoiesis. What do we have here? This is the creation of blood components. Occurs in the bone marrow. Can be affected by numerous factors. The hormone erythropoietin. It can be affected by hypoxia, dehydration, diet, disease, medications. So with hypoxia, well, you have to think about what the various components of blood do. Red blood cells have one job, that's to transport oxygen. If you don't have enough red blood cells, then you can't transport enough oxygen to the tissues. If you don't have enough oxygen, your body is going to produce more red blood cells, enough oxygen in the environment, or enough gas exchange happening, then your body is going to produce red blood cells, more red blood cells, to make the most use of the oxygen that's available. Dehydration can affect the concentration of blood components. Diet, the building blocks for these components. Disease, especially that impacts the bone marrow. And medications that can impact the bone marrow as well. So medications like chemotherapy, some antimicrobials can impact the bone marrow. Blood is considered a connective tissue, and when you think about it, that does make sense because your blood travels to all parts of your body. So how does it start? We have stem cells in the bone marrow. Stem cell is a cell that can differentiate into many different types of cells. In this case, differentiates into myeloid and lymphoid cells. Right now, do be paying attention to the pieces that come out of these because it will make sense later when we talk about blood disorders. So myeloid and lymphoid cells. Myeloid cells differentiate into reds, thrombocytes, so RBCs and thrombocytes, also known as platelets, and some leukocytes. Granulocytes, the fills, and monocytes. These are all from one leg of that initial differentiation. Okay, so you got your reds, you got your whites, and you got your thrombocytes all on one side. In bio, you'll be finding out that the thrombocytes, the cells that actually produce the platelets that are broken down into platelets, are called megakaryocytes, which then are broken down into thrombocytes or platelets. Lymphoid cells, you have your B's and your T's. The B cells are the ones that have memory and produce the humoral immunities. They produce the antibodies. The T cells are sort of the heavy lifters. They go out and they actually attack the invading microorganisms. So let's check out some labs. Oh, aren't they cute? Complete blood count. If we're talking about blood, then a complete blood count makes sense. Gives you red blood cell count for polycythemia, poly, many, cyte, cell, emia, condition of, right? Polycythemia, too many red blood cells. And then anemia, too few red blood cells. Your white blood cell count with differential, which we would be looking for leukopenia, meaning too few white blood cells. Your immune system is not equipped to respond. There's not enough the white blood cells to attack an invader. Or leukocytosis, which is an overproduction of white blood cells, which could indicate that the patient has an infection that the body is responding to, or it could also indicate bone marrow disease. And platelet count. Again, too many or too few, right? Thrombocythemia, too many thrombocytes. Thrombocytopenia, too few, or sorry, well, coffee break. Thrombocythemia, too many thrombocytes, too many platelets. Thrombocytopenia, too few platelets. Platelets are necessary for clotting. They form the plug that starts the clotting process. If you have too many platelets, they tend to bump together and they will form clots in places that you didn't want clots to form, which can then cause thrombuses, emboli, and create some real havoc in the body. Too few thrombocytes and the platelet plugs don't form and you continue to bleed. So as with everything else, a balance is really required. If you have too few, you keep on bleeding, your patient will die. If you have too many and they throw clots in the wrong places, your patient will die. Either way, either end is not a good way to be. So this is what we're looking for very carefully to make sure that our patient is safe. And in peripheral blood smears, well, that's just so we can see what else happens to be in the peripheral blood. Are there other cells that should not be there? Do we have single-celled microorganisms in the bloodstream that should not be there? Is there an infection going on? Are there cell parts? So the peripheral blood smear is just microscopically looking at a smear of blood to see what else is in there. Other studies. The ESR, erythrocyte sedimentation rate. ESR, SED rate. Okay? For infection, inflammation, and autoimmune disease. Now, we've talked in first term, become familiar with inflammation because it plays into so many pieces of the different conditions that we treat, right? Or the different conditions that our patients have who we're treating. So infection, inflammation, autoimmune disease, these are all can cause inflammation or inflammatory disorders. So the SED rate will go up. Blood cultures. Well, as you recall from first week, first term, we're talking about microbiology. When we do a culture, we want to see what is growing in the sample. For the blood culture, we're looking specifically for bloodstream infections. Bone marrow aspiration and biopsy. These are all for hematology, by the way. So bone marrow. Why are we concerned about bone marrow? Because blood is created in the marrow from stem cells in the bone marrow. So we'd be looking for cancer or other blood disorders, or the causes for these blood disorders. Lymph nodes. So your lymphatic system is sort of like the body's storm drain, if you will, with the lymph nodes being the wastewater processing plant. So if we suspect that there is an issue, we may biopsy a lymph node to find out, okay, what has been going on here? If we find cancer in the lymph nodes, then we know that there is a problem. If we find that the lymph nodes are swollen, we may need to dig deeper in to find out what's going on. Looking at tumor staging and diagnosis of different cancers with the lymph node biopsy. So, polycythemia. Let's say the first of ours. Polycythemia. Causes here. Respiratory disease. Renal tumors, dehydration, and hypoxia. Okay, so if you look at respiratory disease, right, so gas exchange happens in the lungs. We breathe in oxygen. We combine that oxygen with glucose at the cellular level. It releases energy and the byproducts, water and CO2. Well, the CO2 has to get out of the body, so it goes back out through the lungs. If the gas exchange is impaired in the lungs, then the body is still requiring, hey, I need more oxygen. I need more oxygen. I need more red blood cells to carry this oxygen, and will begin to produce more. So polycythemia can indicate ongoing respiratory disease. Renal tumors, as we saw, one of the things that triggers blood formation, erythropoietin, which is released from the kidneys. So a renal tumor can cause the increased release of erythropoietin and an overproduction of red blood cells. Dehydration. Now, dehydration may cause what we would call a relative polycythemia, meaning that the number of red blood cells would otherwise be normal, but the patient is dehydrated, has lost fluid, so that the bloodstream is more concentrated. And then again, hypoxia. So we talked about respiratory disease, but think about hypoxia from other causes. Say your patient works underground in a low oxygen environment, then their body is going to be producing more red blood cells to make use of the available oxygen. Or say your patient lives in Denver, lives in a high altitude environment. High altitude, low oxygen. Again, producing more red blood cells to make the most use of what oxygen is available. This is one of the reasons that Olympic teams train in places like Denver, where they're at a mile high that's very thin, and then the games are held generally somewhere at a much lower altitude because, well, the air's thicker there, and everybody does it, and it is simply legal blood doping. They train at the high altitude for long enough that their body builds up a polycythemic state, if you will, and then when they go to the lower altitude, higher oxygen environment, their performance is enhanced, their endurance is enhanced because they have all the extra oxygen carrying capacity. Smoking is one that can cause hypoxia. High altitude, like we just talked about. Environmental exposures. Someone who has been working in an environment that puts them at a higher risk or a higher level of exposure to carbon monoxide can be polycythemic, because carbon monoxide will bond tighter to the hemoglobin in blood than oxygen will. And once it is bound to the hemoglobin, that hemoglobin can no longer carry any oxygen. So then the body makes another red blood cell to replace the oxygen carrying capacity that is lost. That's just one example. So let's look at our effects. So polycythemia, so we have more red blood cells, can increase blood viscosity. So think let's see. Think a cup of water versus a cup of maple syrup. Which pours faster, which pours easier? Right? The maple syrup is more viscous. It travels a little more slowly. Okay? It has increased viscosity over the cup of water. So we could have cephalgia, your new favorite term. Cephalgia simply means headache. Angina, again, another of your new favorite words. Angina is chest pain. Specifically, heart. Can cause thrombosis, emboli, and hemorrhage due to vessel damage and increased pressure. Can cause respiratory distress from hypoxia. Wait a minute, hypoxia? But I have all of this excess oxygen carrying capacity. I have all these extra red blood cells. Because there are so many that the blood is viscous or is more viscous and flows slower, that increased oxygen carrying capacity actually does no good. And then can cause occlusion of the blood vessels. Just to give you an idea of that, well, again, I would go back to the syrup analogy, the maple syrup analogy. If you take the bottle of maple syrup directly out of the refrigerator and pour it, it doesn't pour well, right? the thicker it is, the less it's going to flow, and it can cause the blood vessels to actually block. Okay, treatments. Wherever possible, treat the underlying cause. And this is the case with, with anything that we may be treating as nurses, as medical professionals. Treat the underlying cause. If we can't treat the underlying cause, all we're going to be doing is chasing symptoms. So for hypoxia, supplemental oxygen. Therapeutic phlebotomy to reduce the total count. Okay, therapeutic phlebotomy. This is one thing that the Old West dentists had right. They would bleed their patients. Dentists and doctors, sometimes there wasn't a whole lot of difference. They would bleed their patients. In this case, yes, actually removing some of the blood volume and replacing it with fluids is used to treat polycythemia. Bone marrow suppression. Because the bone marrow is where the blood components are being produced. If the bone marrow is going crazy and producing too much, we may need to suppress the marrow itself. Hydration. So for that relative polycythemia that we talked about earlier with the dehydration, well, they get fluids to help correct the fluid balance and thin out the blood. Low dose ASA. ASA is aspirin, acetylsalicylic acid, aspirin. Its effect, it makes the platelets just a little bit slicker. Inhibits their sticking together so that they are less likely to clump together and form clots and create more havoc. Now let's look at the other end of the spectrum. Anemia. Can be iron deficiency. Wait a minute, iron? Hemoglobin. Hemoglobin is made of iron and proteins, and its job is to transport oxygen. If you don't have enough iron to make the hemoglobin, you don't make hemoglobin, you don't make red blood cells. So dietary, either an inadequate absorption, so you're not getting enough in your diet, or excessive loss of Fe, iron. Hemolytic anemia, early destruction of red blood cells. Various toxins, trauma, procedures, medications, and sometimes genetics plays into this, but medications to include IV fluids. Giving the wrong IV fluid, the wrong tonicity, can cause red blood cells to pop. And then they have to be replaced, but they don't replace them very fast. Acute hemorrhage. Yeah, it kind of says it all right there. It's acute, it's fast, it's a hemorrhage. Chronic hemorrhage. Okay. So you'll see this more in cancer and GI bleed patients, chronic gastric ulcers. Tends not to be, super fast blood loss, but consistently over time can make the patient anemic. Pernicious anemia. Lack of intrinsic factor. Okay, now what is intrinsic factor? Intrinsic factor is the piece needed to absorb B12 from the GI tract, and we require B12 to utilize the iron to make the hemoglobin. If you don't have B12, you don't utilize the iron, you don't make the hemoglobin. Now there's a couple of types. There's pernicious anemia, where the stomach is not producing intrinsic factor, and this is produced in the stomach. And it doesn't matter how much B12 you take in your diet. You could take all the oral B12 that you could handle, and it still would not be getting absorbed. Back up here just a second. Now, the B12 deficiency anemia is totally dietary. And we tend to see these in patients. So, with pardon me. So, in the patients with a lack of B12, if they have been on proton pump inhibitors for an extended period of time, they will likely be B12 deficient, because the proton pump inhibitors, the PPIs, for gastroesophageal reflux disease, will also not only suppress the production of stomach acid, but the production of intrinsic factor. B12 deficiency, we tend to see this in strict vegetarian and vegan diets who do not supplement. Because because the major source of B12 in our diet comes from animal proteins. Aplastic anemia. It's just not being made. Could be chemo has affected the bone marrow. Radiation has affected the bone marrow. A virus. Ingested or injected or inhaled toxins. An autoimmune disorder, and sometimes we just don't know what has caused the aplastic anemia. And then overhydration. Now, as we saw previously with polycythemia, dehydration made the bloodstream more concentrated. So an otherwise correct number of red blood cells was too many in that case because the fluid balance was off. This is the other end of that spectrum. Sufficient number of red blood cells, but so much excess fluid that the bloodstream is dilute. If that makes sense. Oh, look. Okay. Now, here we go for some fun. What are the effects of anemia? Well, pallor. Now, there's a difference between pale and pallor. Dan is pale. Pallor, once you see it, you will never forget it. Fatigue and activity intolerance. Dizziness, weakness, jaundice from liver impact, long bone and sternum pain. Why would we have long bone and sternum pain? To answer that question, I think I would look at where the bone marrow that produces red blood cells or blood components is. And labs decreased red blood cells and a decreased hemoglobin and hematocrit, or H&H. GI complaints, irritability and sleep disturbance. So consider your red blood cells carrying oxygen. Consider how you feel without sufficient oxygen. Can cause some irritability, some anxiety, and can make it difficult to sleep because you're feeling constantly short of breath. Look, short of breath. Tachycardia and hypotension. So when we start thinking about blood volume and oxygen demand, this is where we talked last term about being all about the puzzles. Well, now here's puzzle pieces to put together. Your body wants to maintain homeostasis, a perfusing blood pressure. So if I lose red blood cells, my blood volume goes down. My body says, hey, I'm not getting my blood volume goes down. My blood pressure goes down. My body says, hey, I'm not getting enough pressure here. Gotta up the cardiac output. So the heart, in response to this, picks up. It picks up its rate to try to keep the cardiac output to meet the body's metabolic demands. And for men and women, menstrual issues and impotence is another from anemia, again from a volume. Well, for men, it's from a volume perspective, and menstrual issues for women, you may have dysmenorrhea or amenorrhea, depending on how severe the anemia. Treatments. If I'm low on red blood cells, and if I'm low on volume, I wonder what those treatments are going to be. Got some ideas yet? All right, here we go. Treatment depends on the cause. In most cases for red blood cells, or in most cases of anemia, just packed red blood cells. Because, well, anemia, you're short on the red blood cells, you don't need to replace the rest of it. So in most cases, concentrated, packed red blood cells are what is required. Now, if you have a relative anemia due to overhydration, then diurese. Get the excess fluid off. Acute hemorrhage, well, one, stop the bleeding, but two, you're giving whole blood because you are not just replacing the packed red blood cells, you're replacing the plasma and everything else that is being lost onto the floor. For pernicious anemia, B12 injections. So why would it be B12 injections versus a pill for pernicious anemia? Go ahead and pop that one into the comments down below there. Why it would need to be injections instead of the pill. Iron deficiency anemia. Fe, iron, supplement. Can be oral or parenteral. Parenteral meaning injections or infusions. Getting it into the bloodstream. Hemolytic anemia. Depending on the cause, corticosteroids may be the cure. A splenectomy may be necessary. And aplastic anemia, it may be time for a bone marrow transplant. Okay, still with red blood cell disorders, sickle cell disease. Genetic condition causes the red blood cell to be crescent-shaped, malformed. It's a mutation of the shape of the hemoglobin. It has a genetic link to the malaria belt. Can cause hypoxia. It interferes with oxygen transport, the amount of oxygen that can be transported, and the ability of the sickled red blood cell to move freely throughout the entire body. We get jaundice, fever, pain, impact on the liver, causing the jaundice. Pain, extreme pain, may be localized to areas where sickled cells have clumped together and blocked blood flow. These can be life-threatening. Dark urine, renal failure, dark urine from liver impact as well, and the tubules in the kidneys becoming plugged up with sickled red blood cells. This is no cure for sickle cell at this point. It can really shorten the patient's lifespan. Thalassemia. Again, deficient or damaged hemoglobin. Again, a genetic link to the malaria belt. Can cause anemia, deficient or damaged. In this case, the red blood cells are normally shaped. Fever. Failure to thrive, FTT. We generally, think of this as in infants. Failure to thrive. They just do not develop well. Very thin. They don't eat. They don't take in nourishment. They're just almost starving to death before your eyes. An enlarged spleen. Splenic tenderness. Impaired growth and development. So why would we have impaired growth and development if we didn't have enough hemoglobin? Consider what is required for growth and development of structures. You have to have energy. You have to have glucose being burnt with oxygen to create the energy for your cells to carry on their growth and development tasks. Right? Without energy, life stops. So if they're not getting sufficient oxygen to those tissues, then those tissues are impaired. They're slowed in their growth and development because they're not able to produce enough energy to perform their processes. White blood cell disorders. Neutropenia, agranulocytosis. Right? Oh, big words. Neutropenia is a decrease in neutrophils. Right? Neutropenia, so why do we need our neutrophils? Why do we need our white blood cells? because they are the big guns in our immune system. Okay, white blood cells are the warriors of the immune system. Agranulocytosis, so neutropenia is a decrease in neutrophils. Agranulocytosis, severe neutrophil deficiency. Neutropenia, at risk for an infection. Agranulocytosis, really at risk for infection. Leukemias, ALL, CLL, AML, CML. Now, acute lymphoid, acute myeloid. Where have I heard lymphoid and myeloid before? If we look all the way back to the start of the presentation, where we have the myeloid cells and the lymphoid cells, the myeloid cells cascaded down to the left of your screen with the red blood cells, the thrombocytes, and the fils, and the monocytes, and your lymphoid cells turned into your B's and T's. Okay? So, ALL would affect the B's and T's. AML could affect reds, whites, and thrombocytes. All three. So, looking at these, an acute lymphoid versus chronic. Acute comes on fast. Chronic is going to be there forever. So think about what the name means here. Acute lymphoid leukemia, which side of the tree is that on? Acute myeloid, which side of the tree is that on? What is on that side of the tree? So, neutropenia and agranulocytosis. Signs and symptoms of infection, usually respiratory. Why? Because, well, those seems to be the easiest ones to get. And headache, fever, malaise, general feeling of ick, fatigue, chills. Leukemias, same symptoms, but add symptoms from damage to red blood cells, white blood cells, and platelets. So you get anorexia, bone pain, bruising, bleeding, shortness of breath. So anorexia, and I need to remind folks each time that this is when we say that someone is anorexic. We are not necessarily talking about anorexia nervosa. We are talking about anorexia not eating or not taking anything in. Bone pain. So would bone pain be from the bone marrow trying to up production of white blood cells? Right? Bruising and bleeding from damage to the platelets. Anemia from damage to red blood cell production. So we're seeing where these pieces all tie together. It's the puzzles, my friends. I love this stuff. Now let's look at the storm drain. All right, Hodgkin's lymphoma. How many types of Hodgkin's lymphoma are there? I'll give you a hint. There's one type of Hodgkin's lymphoma. It's Hodgkin's lymphoma. The rest of it is non-Hodgkin's lymphoma. So Hodgkin's has the Reed-Sternberg cells. In your book, I don't have the page number in front of me, but there's a lovely picture of a Reed-Sternberg cell. Gives you abnormal B cells and can affect both the young and old. Hodgkin's lymphoma. Non-Hodgkin's. Now, there's over 60 different types of non-Hodgkin's lymphoma. Get abnormal B and T cells. So these are the lymphocytes. These are on that right-hand branch of the tree, right? Generally hits people over the age of 60. So generally the old. Multiple myeloma. It's a malignant cancer. Hypercalcemia, pathologic fractures, osteoporosis, dehydration, and fatigue. Let's talk about this for just a second before we go on. So, your bones, besides providing support for everything else, are also a wonderful storage place for your body to store calcium. In fact, it's the best thing to have stored in your bones because it helps to give it strength. When we're talking hypercalcemia here, we're talking hypercalcemia in the serum, which means that the calcium level in the bloodstream is very high. What this is meaning is that the calcium has been taken out of the bones and is in circulation in the bloodstream, which then weakens the bones and can lead to the osteoporosis, the pathologic or disease-related fractures. Okay, those three go right hand in hand with each other. Confusion, altered level of consciousness, and coma. Pneumonias, pyelonephritis, and renal failure. Kidney, inflammation in the kidneys, renal failure, renal calculi because of the hypercalcemia. This is not a pleasant cancer, if such a cancer actually exists as a pleasant cancer, but this is not a pleasant thing to have. The pathologic fractures, these patients break easily. Now on to platelets, or thrombocytes, and clotting disorders. Clots are important. They stop us from bleeding, but they can cause some big issues in the body if they are laid down or form in the wrong place. Let's start with thrombocythemia. So it's an overproduction of platelets, and it may cause occlusions in the bloodstream or hemorrhage from increased pressure, damage to vessel walls. We have this overproduction, and it can cause vessels to break. Treatment for thrombocythemia with aspirin to make them a little slicker, or chemotherapy to suppress the production in the bone marrow. Now you think about it, if we are suppressing the bone marrow, we're not just going to be suppressing the production of thrombocytes, but we're also going to be suppressing the production of our reds and whites. Hypocoagulability, too low, right? Thrombocytopenia, possibly autoimmune in nature. We have disseminated intravascular coagulation, meaning that the clotting cascade has been triggered and clots form throughout the body. Now, this is under hypocoagulability because once this cascade has been triggered and all these clots are formed, the platelets are used up and the patient is now thrombocytopenic. So if they bleed, then they will continue to bleed because they don't have the platelets to stop the bleeding. DIC, disseminated intravascular coagulation, or coagulopathy, can be the result of infection, sepsis, trauma, should be a comma there between sepsis and trauma, or complications of childbirth, which is especially frightening as childbirth is a process where bleeding occurs. Hemophilia. So it is generally sex-linked, mostly males. Okay, it's a genetic mutation. Von Willebrand's disease. The most common bleeding abnormality in humans. Now, when we say the most common bleeding abnormality in humans, happily, bleeding abnormalities are not very common in humans, but this would be the most common. It is the deficiency of factor VIII and von Willebrand factor, parts of the clotting cascade. Signs and symptoms of internal and external bleeding, potentially fatal, because if you can't coagulate, if you can't stop the bleeding, it's going to continue. Coagulation studies. So the labs that we would be looking at for patients with potential bleeding disorders or on medications that can impair clotting. Right? First off, we're looking at prothrombin time, the PT, pro time, the PT-INR. These are the same studies. These, we would be monitoring the effects of Coumadin and or warfarin, what your patients may refer to as their rat poison. These are anticoagulants that affect the conversion of prothrombin into thrombin. The partial thromboplastin time, the PTT or APTT, measures the heparins, the effect of the various heparins, whether it be the low molecular weight heparins or like IV heparin itself. With the PTT and the pro time, the PT and the PTT, they are different parts of the clotting cascade. So a patient could be on a heparin at the same time they were on warfarin, and the heparin would not affect the PT. Only the warfarin affects the PT. If they were on warfarin, it would not affect their PTT. So, things to know. When I think of PTT, I think the two T's together make an H. H for heparin. Whatever works for you to remember the two, but you've got to know the difference between them because it's two completely different drugs. Heparins take effect sooner and wear off faster than warfarin does. So a patient will often be started on heparin to get them to a safe level where they're not clotting too fast. while the level of warfarin is being built up in their bloodstream, because it takes longer to do that. And then the heparin can be discontinued without affecting their overall um, coagulation. It's called a heparin bridge. And in bleeding times, we won't get too heavy into bleeding times unless you're working in hematology. But aspirin tolerance, oddly enough, how quickly and how markedly your bleeding times react to aspirin. And these are looking at platelet disorders. So, signs of bleeding, internal and external. Let's look at internal first. Restlessness, tachycardia, and hypotension. The hypotension likely causing the tachycardia. The hypotension because you're losing circulating blood volume. If you're bleeding internally or bleeding externally, that part that you're bleeding is no longer circulating blood volume. And for cardiac output, your body does not care about it once it stops circulating. So no longer circulating blood volume, body triggers a response to up the cardiac output. So you get tachycardia. May get a headache, and this may be as a result of where the bleeding is. If the bleeding is intracranial bleed, there will be some headache involved. Pallor, again, with the decrease in circulating blood volume, not as much as getting to the surface, or to the core organs, and body begins to shunt away from the surface, giving the skin a very pallid look. Signs of a CVA. Joint pain and swelling, if the bleeding is in the joint. Hematuria, blood in the urine. Hematemesis, vomiting blood. That can be both an internal and external bleed. Blood in the stool. Shock. Now, recall back to first term, as we're talking about shock. Remember that shock is a precipitous drop in blood pressure. So, in this case, when we have bleeding, we have a lowered blood volume that would be hypovolemic, and it would be hypovolemic shock. So external, purpura, purplish patches on the skin. Right? Petechiae, little red dots. Your book has a great picture in there showing the little burst vessels that are petechiae. Epistaxis, nosebleed, bleeding from the gums. That is external bleeding. Thrombocytopenia. That's the labs will show up because with external bleeding or internal bleeding, both, if they're trying to form clots and they're being unsuccessful, the number of available platelets is going to drop. Conversely, thrombocytopenia could also exacerbate internal and external bleeding. Menorrhagia, right? Menstrual bleeding, severe menstrual bleeding. And, well, if there's a pool of red stuff on the ground beside them, that's kind of a dead giveaway there. Oh, speaking of death. Death is a late sign, a very late sign of internal or external bleeding. If you have gotten to death, you missed something else here. on the way there. So common treatments for bleeding. Transfers of colloid solutions. Right? So hypertonic solutions, so a little more concentrated than the bloodstream to increase the circulating volume. Transfusions of blood and blood products. Obviously, if you are bleeding profusely, you need a replacement of the whole blood that's being lost. But maybe you just need plasma. Maybe you need a bag of platelets to replace the platelets that you've lost. So here we have the blood and blood products. So autologous transfusions. This is the patient who donates their own blood prior to a procedure, banks their own blood in case they need it this is the safest type. There is no risk that you are going to be allergic to your own blood. Allogenic transfusion, that's blood from a donor, same species. The blood is type matched to the patient. So type A, type O, type B, positive or negative, and then screened for disease. What's that, you say? Screen? Typing? What? Here we go. ABO blood typing. Direct and indirect Coombs test. Type and screen test. Type and cross-match test. We do all of these tests. All of these because it is extremely important that the client gets the right blood type that matches their own antigens and antibodies. Extremely important, because this can kill the patient. Wrong type of blood can easily be fatal, and once you have given it, there's no taking it back. So having it done right the first time, the type and screen, the type and cross-match, making sure that the blood is double-checked. 2 licensed nurses. There's an entire section there in your book about how blood transfusions are done. Pay close attention to that. You may not be initiating the blood transfusion as the PN, but that does not mean that you do not have a responsibility to your patient to be, when you're monitoring the blood transfusion, or when you are observing or assisting the RN in initiating that blood transfusion, to make sure that everything is correct. Just a wrong type of blood could easily be fatal. So let's talk about blood types. This is sort of fun. I like this graph. I like this graph a lot because it does lay it out pretty easily. You can refer back to this in the PowerPoints at any time you want. So, type A blood. Type A blood has the A antigen on the surface of the red blood cell. In the serum has the anti-B antibody. Okay? So, type A, anti-B. Under type B, has the B antigen on the surface of the red blood cell, and the anti-A antibody in the serum. So if you look, if I have type B blood, if I'm giving a type B blood product to a type A person, the type A person's anti-B antibodies are going to directly attack that. The same if I was to give type A blood to the type B patient. Type AB, universal recipient, has no anti-A or anti-B antibodies. Type AB can get blood from everyone. If you see down here on the chart on the left there, 1, 2, 3, 4 lines down, AB positive can get blood from everybody. All the way to the bottom, AB positive can get blood from everybody who is, AB negative can get blood from everybody who is negative. We'll get to the RH factor here in just a moment. Type O, we're the universal donor. I'm a type O positive myself. I have both anti-A and anti-B antibodies, so I can only receive blood from other type Os, but I can give blood to everybody. Well, in my case, type O positive, I can give blood to everybody who is positive. So O positive, A positive, B positive, AB positive, everybody's good. Type O negative could donate to everyone. The drawback to the type O negative is they can only receive blood from O negative donors. The RH factor, the D antigen, that is where we hit our positive or negative, right? It's RH positive, RH negative. So this is independent of blood type, right? Positive may donate to positive, as you can see here with your with the graph down below. Negative can donate to anyone, because if you don't have the RH factor on the blood cell, then nobody's RH antibodies are going to attack it. However, if you don't have the RH factor in your blood, and you get RH positive blood, then you can start a reaction. So positive can donate to positive, negative can donate to anyone, making O negative the universal donor and AB positive the universal recipient. So, blood products. We talk about transfusing blood and blood products. Well, what the heck are they? So, packed red blood cells for anemia. Platelet concentrates. We've spun out the platelets. Thrombocytopenia, or active bleeding, where we need to load on some platelets to try to get this trauma patient to quit bleeding out on the floor of the emergency room. Fresh frozen plasma, which has the other clotting factors in it. Serum albumin. Albumin is a protein made in the liver, if you may recall from Nursing 103. And this can be used to treat hypovolemia, burns, liver, and the results of liver dysfunction, because if the liver is not working, it's not producing albumin. Serum albumin helps to hold fluid into the bloodstream, and it is also a protein used to build other body structures. Cryoprecipitates, again for clotting disorders. Immunoglobulins, so provides short-term immunity. Think treatments for viral exposures that we can't make antibodies for, say rabies. And it provides short-term treatment, short-term immunity. Now, plasmapheresis, apheresis, this is separating this out. So let's look at, we have immunoglobulins, cryoprecipitates, serum albumin, FFP, platelet concentrates, packed red blood cells. From 1 unit of whole blood, you have 6 separate blood products. That kind of puts that donation into a different light, doesn't it? That 1 unit of blood can affect 6 different people. Blood administration. Here we go, because it can be scary. It is a tissue transplant. You don't have to be on a transplant team to do a transplant procedure. Blood administration is a tissue transplant because, as you recall, blood is a connective tissue. It requires 2 licensed nurses, not a nurse and a CNA or a nurse and a family member, 2 licensed nurses. There's a special ID band for the patient that has a distinct, discrete number for that patient and the blood bank. Blood is typed and cross-matched for each patient. So if the order is to type and cross-match 4 units of blood, then the patient will be drawn for the type and cross. They will be cross-matched to 4 specific units of blood in the blood bank. And those 4 units belong to that patient until they are either given or they are released from the blood bank. Except in emergencies. And in emergencies, we go for type, what was it? The universal donor? Everybody's screaming at your computers now. It's type O negative. I just got this visual of everybody screaming at their computers, and it made me giggle inside just a little bit. Yes, type O negative in emergencies. Mistakes can be fatal. And when you are looking at Nursing 201 and you're looking at sentinel events, some of these transfusion reactions may be sentinel events, especially since these are things that could have been avoided. Trali. T-R-A-L-I. Well, it's kind of a descriptive name. Transfusion-related acute lung injury. Inflammation, inflammatory process, systemic inflammatory process, causing the lungs to become edematous. This can be fatal to the patient. So let's look at reactions by the system. Generalized. Fever, chills, shaking, pain, headache. Sounds like a severe immune response. Because it is a severe immune response. Pain in the back, in the flanks, kidneys being affected, in the chest, with the heart and lungs, as the body is reacting to this foreign invader, this wrong blood type, and it is triggering the immune response and triggering those blood cells to clump together in a process called agglutination so that they can be taken out by the immune system. This can cause blockages in the red blood cells, or in the blood vessels by red blood cell clumps. Integumentary. Rash, inflammation, hives, and sweating. Again, sounds an awful lot like an immune response. Apprehension and doom, tingling and numbness. Changes in heart rate and blood pressure. Blood pressure is likely to tank as the patient goes through anaphylaxis and into anaphylactic shock. Heart rate will increase, trying to keep up with the metabolic demands of the body and increase the cardiac output. Respiratory. Changes in respiratory rate. Tachypnea, dyspnea, cough, abnormal breath sounds as the lungs become edematous. GI, nausea, vomiting, diarrhea. Body is trying to purge any way that it can. Urinary, changes in urine output and color. It's likely to turn red, then brown, and then slow way down. As you can see from this cluster of symptoms, this is not any way we want our patients to go. So, following procedure, making sure that everything has been checked, that you have the right patient, that you have the right blood product, that the blood band numbers match, that everything is done right to avoid these reactions. In theory, these reactions, these events should no longer happen because we have procedures in place to stop them from happening. But they still do. So knowing what to look for, expect it to go wrong. If it doesn't go wrong, wonderful. You've just saved a whole lot of paperwork and your patient's going to have a great day. If it does go wrong, then you are prepared. One of our last pieces here, coming up on the end. We're almost there. Hematopoietic stem cell transplantation. That's a mouthful. All right. HSCT, bone marrow transplant. Hematopoietic stem cells. So remember all the way back at the beginning, like an hour and 17 minutes ago, when we were talking about where blood components come from. You have your hematopoietic stem cells splitting into the lymphoid and myeloid, into your reds, whites, thrombocytes, monocytes, and your B's and T's. Just memorize it. So, stem cells are taken from bone marrow, cord blood, or we're finding stem cells in places we didn't know they existed before. So even in peripheral blood, we find stem cells taken and developed from there. Right? So how do we get them? Where do we get these from? Well, sources for bone marrow. I mean, amniotic cord blood kind of says it in the name right there. Or, I'm sorry, umbilical cord blood kind of says it right there. Sources for bone marrow. Maybe autologous. Why would I donate my own bone marrow? If I'm going to have a bone marrow transplant, doesn't it mean my bone marrow is bad? Consider this. I have cancer. I am going to have to get some pretty heavy-duty chemo and radiation, and it's going to knock out my bone marrow. What do? I donate my own bone marrow prior to the procedure, go ahead and have my chemo and radiation, and then take my own bone marrow back. Does that make sense? That would be a time when you would do that. Syngenic. bone marrow from a twin. Allogenic. So from another human that has the same human leukocyte antigen, leukocyte-associated antigen, the same HLA. So you can see that these are a lot of the same things we look at for blood donation, but for blood transfusions, but just a bit tighter, a little more extreme, I guess, with instead of just the blood typing, we're also looking at the human leukocyte associated antigen. And that is the end of that. That's the end of week 1. Enjoy. Post questions in the comments, or you can email me directly, and I will do my best to get all the answers out as quickly as possible. Have a great day.